what would you recommend to someone who's working in the neurotechnology field and wants to have an impact on mental health? What would be the greatest unblock for the three of you?
Well, I mean, I'm biased by my own area, but I mean, we already discussed the challenges with data, right? So how, when you talk about mental states, unlike traditional brain-computer interfaces that we're talking about, decoding movements or speech, where the behavioral data is not that sparse. In the case of mental disorders, if you think about developing neurotechnologies, one major challenge is the sparsity and inaccuracy of the behavioral labels that you then correlate brain activity to. And I think that combined with the network level representation in the brain that these symptom states have, and that basically changes the types of computational challenges that one has to address to build these technologies that can in closed loop decode symptom state, that can provide the right amount of therapy, dosage of therapy in order to basically alleviate symptoms and help patients in the longer term. So I think just innovating on the machine learning and modeling front for these particular challenges that are distinct from the traditional BCIs is something that I am very excited about, and my students are, and I encourage others to also think about these problems on the computational side.
What do we see happens when we've collected this mapping of symptom states to electrophysiological correlates? We start doing some cluster analyses and find that there are indeed these very interesting clusters of symptom states that correlate with biology, and then all of these groups weakly correlate to the DSM. What happens in psychiatry when it turns out that a lot of things that exist in the DSM don't map very well onto these new explanations and these new descriptions? How do we move forward as a field?
So I think we already know that that's true. I mean, we've known, every clinician knows that it's true. And there's this sort of like way people refer to it, essentially, that people use DSM for coding to get reimbursed. But that's not even really it. DSM had a utility back when it was started, which was a common language, which at the time people were like the same patient would be diagnosed by two different clinicians with two totally different disorders based on their theoretical, background and training. That's like a non-starter to begin with, right? Because we're not even literally speaking the same language. But I think every clinician knows that DSM is not really our anchor. Every clinician knows that there's certain drugs that they go to that have a certain response rate. It's all still trial and error, but they often prescribe drugs fairly flexibly across categories and might see the patient as potentially benefiting from one thing or another more empirically than based on their diagnosis. We've published years ago about brain imaging studies across diagnosis telling us that there's much more commonality than there are differences. But I think what's exciting and around the virtual room here, what's particularly exciting is actually the ability to intervene. And that, I think, is what will get clinicians excited is, okay, now you have this biological understanding. Let's just put DSM to the side because we're not trying to either prove or disprove it. Now you're telling me that this patient is different from that patient. Great, but what can you do about this? And that entry point, that's really, really where we are today in that exciting time where if we could show that you get a different outcome by knowing something about a patient at the brain level, that changes expectations clinically massively.